everybody, I am Dr. April Steele, Doctor of Nursing Practice. I am here with a video abstract to share with you about my quality improvement project, aptly named Reducing Mental Illness Healthcare Provider Stigma, a quality improvement project in rural primary care practice. The results from my quality improvement project shows that after healthcare providers were exposed to a pre-test, post-test quantitative design, the healthcare providers documented in the electronic health record during each patient interaction for a month following. They noted changes in clinical practice behavior as seen by comprehensive mental health care documentation and patient satisfaction scores. 62.5% of healthcare provider respondents indicated that they could easily or slightly easily address mental illness stigma in their clinical practice. The pre-stigma scores, the mean score was 51.31 and the post-educational score was 42.37. It was not deemed statistically significant with a p-value of 0.129. 93.75% of respondents improved their scores on the evidence-based tool from pre-test to post-test. There was clinically significant change for respondents who had indicated an inclination towards disclosure of a mental illness. This dimension can be used to provide an indication of stigma that healthcare providers feel exists if a mentally ill person attempts to seek primary care. The first dimension was statistically significant between pre-test to post-test with a t-value of 5.689 and a p-value of less than 0.0001. Using matched data, individual changes on the OMS-HC evidence-derived tool from pre-test to post-test showed statistically significant scores from baseline for this dimension. The CPDR scores for intention to change clinical practice were high, in particular for the construct of moral norm and belief about consequences of stigma. 150 patient satisfaction surveys indicated that 75.3% of patients experienced staff that had introduced themselves. Introduction by healthcare providers correlated highly with patient responses about having questions answered to their satisfaction, with an R value of 0.932 and a P value of less than 0.001. Feeling they received quality care with an R value of 0.843 with a P value of less than 0.001. And having fears reduced during their clinical interactions with an R value of 0.932 and a p-value of 0.0001. Chart audit documentation revealed a 63.76% positive change in documenting required mental health care action plans between the pre- and post-test educational intervention, along with a 72.7% increase in comprehensive mental health care documentation regarding expected patient outcomes for mental health documentation. My conclusion is that understanding meaningful ways to improve and measure a practice change to decrease mental illness stigma may result in improved patient outcomes, as seen by improved patient satisfaction. The results informed healthcare providers about stigma prevalence at this particular clinical site. The Quality Improvement Project may be used for future continuous professional education, measurement of quality clinical outcomes, and additional quality improvement projects.